Welcome, everyone, to our continuing series on emergency medicine and trauma. Today, we're going to talk about head injuries and traumatic brain injuries, or TBIs. Now, come on, admit it. You all just read that with Arnold's voice in your head, right? Anyway, I want to let you guys know that today we're going to talk specifically about what we do for a suspected TBI in the trauma bay. We're not going to get into subdurals or epidurals or the type of brain injuries. There are some great lessons in the neuro section of NRS&G. So if you want some more information on the specifics, head over there and check it out. You know, after we're done here, of course. So when it comes to TBI, there are some pretty common ways they can occur. You got your motor vehicle accidents, your falls, your sports injuries. Now, bear in mind, with falls, you don't have to fall very far. A fall from standing can cause a TBI if a person lands on their skull, right? So in that vein, we want to know what happened. Any detail is going to help us with our diagnosis and, our further treatment. So if our patients are awake, what are his complaints? Headache, blurry vision, I can't feel my legs. Our patients are always going to be our greatest source of information. So it's important when you're trying to diagnose a TBI to keep the thought of drugs or alcohol in the back of your head. Many times I've seen a patient brought into the trauma bay, quote unquote, found down, who's confused, he smells of alcohol. It's one thing to think of him as like a common drunk and treat him like that. But seeing as how there are no witnesses to his falling down, you might want to get a CT scan to make sure his altered mental status is actually due to his intoxication as opposed to a brain injury. So there are some signs of a major complication that we can see. First, and really easiest to assess, is the level of consciousness, right? Are they ANO times 4, alert and oriented times 4, and that's person, place, time, and situation. Now, I know situation isn't one used by everyone, but it's telling if your guy knows who he is, where he is, what day it is, but he can't remember a thing about the accident or why he's in the hospital. We want to watch for posturing, and we're going to talk about two specific types related to TBIs. Decorticate, C-O-R-T-I-C-A-T, decorticate and decerebrate. Decerebrate. And I apologize for the handwriting. Decorticate posturing is when the arms are drawn up to the chest and the hands are clenched. And the way to remember this is decorticate, or towards the core. Decerebrate is the kind of involuntary extension of the upper extremities, where they're pointed straight down. And the hallmark to this is, the arms and legs are kind of rotated internally, but the hands and the wrists are rotated away from the body. Now, both of these are really ominous signs of a severe injury. So then we move on to the pupils. You look at them. Are they reactive? Are they dilated? Are they pinpoint? And most importantly, are they equal? Like this guy. Obviously, you can see one pupil's dilated, one pupil's pinpoint, right? So unequal pupils in a suspected TBI is really indicative of that brain injury. And then hemiparesis or hemiplegia. If your guy's losing feeling on one side of his body, or he can't move one side of his body, I think it goes without saying, there may be a problem. The question is whether this is an injury to his spinal cord or whether this is a brain injury. So when we do our assessment, as always, it's ABCs first, guys. So airway, we want to check the rate and the depth of his breathing. Pupils, we just talked about that, right? PERLA, when you see that documented, PERLA is P-E-R-L-A. Pupils equal, round, and reactive to light and accommodation. It means you shine light at them, they react normally, they're equal, good. Posturing, we just talked about that. Blood, we want to know where it is. Is it on his skull? Can you tell where it's coming from? Is he leaking from his eyes, ears, nose, mouth? And by the way, blood leaking from a hole that he already has, this is where we don't want to put on direct pressure. We don't want to cause increased intracranial pressure if we can avoid it. And if there's a skull fracture causing leaking from one of these holes, you can bet that the brain's starting to swell. So some common signs associated with head injuries. So periorbital ecchymosis, so bruising around the eyes, or raccoon's eyes, sign of a basilar skull fracture. Battle sign, that is kind of bruising. It's called mastoid ecchymosis. It's bruising behind the ears almost, sign of kind of a mid-skull fracture. And then halo sign. Halo sign is basically if you see some fluid leaking from the head, you put a drop of that on like a 4x4 piece of gauze, and what you'll see is the blood in the center and then kind of a yellow halo around. So you get the blood in the center, and then you'll see this yellow halo around, which is, well, there you go, halo sign. And what is it a sign of? is usually it's a sign of cerebrospinal fluid. He's leaking CSF from somewhere. Obviously not a good sign. And then GCS, or Glasgow Coma Scale. We want to assess this properly, guys. Motor response, verbal response, eye-opening, 3 categories. It's scored from 3 to 15 total. There are no zeros in GCS, guys. I've said it before. Your computer screen technically has a GCS of 3. No eye-opening, no motor response, and no verbal response, right? So when we assess GCS, there's this old trauma saying of less than 8, intubate. And what that usually means is that the patient's level of consciousness is so low that he can't protect his own airway. It doesn't mean he's not breathing, but there's concern that his neurological status warrants that ET tube. So what do we do in the trauma bay? Well, first thing we got to do is establish and maintain that airway, right? Good. We get IV access. And none of this 22 gauge nonsense, guys. Go big or go home. 18 gauge, 16, 14. The larger you can get, the better. A true trauma patient is going to need fluids, blood, and he's going to need it quickly. You want to be able to get it into him as fast as possible, so we want the biggest opening we can maintain. Think of it this way. Is it easier to pour water through a straw or a garden hose? Exactly. So we want to position our patient properly. Usually after our assessments are completed and the C-spine's cleared, we might want to raise the head of the bed to like 30 or 40 degrees. It's enough to facilitate blood flow, but not too high or too low to cause more intracranial pressure. So we want to think about medications. Mannitol is kind of a standard in the trauma bay for reducing intracranial pressure. It's an osmotic diuretic, and it helps to kind of reduce that fluid buildup in the brain. If we're concerned about seizures, which can be pretty common in TBIs, we can give some anticonvulsants, drugs like Dilantin, Keppra-Valium. I would check with your facility on their protocols with medication and TBIs. Always remember, radiology is our friend. We can't really diagnose a true TBI unless we can see the brain. And if they're stable enough, get them over to CT. Now, while labs aren't the first priority, they are important. We want that tox screen. We want that alcohol level. And sometimes the labs can kind of tell us if there was a medical issue that caused the events leading up to the TBI. So now, if the pressure is great enough and it really can't be relieved by our conventional methods, our wonderful neurosurgeons, they might have to pull out their power tools like this thing right here. That is a power drill, all right? With this, they're going to perform a craniotomy. Basically, that is drilling holes into the skull to relieve the pressure. And trust me, I have seen fluids shoot 10 feet across a room from a craniotomy hole. It is really impressive. So once the holes are drilled, they'll usually insert an intracranial pressure monitor into the opening to keep an eye on that pressure. This is sometimes referred to as placing a bolt. And why? Well, because it kind of looks like a bolt that you would screw something in with. So some basic concepts for you guys. We have to use our clinical judgment. When they come in, is this a TBI? Is this metabolic? Are they just drunk? We have to maintain that intracranial regulation, whether through position, medication, or if we need it, invasive procedure. And we have to prioritize. ABCs first as usual, but then what are our next steps? What's the pressing issue for our patient that needs to be corrected? So a few key points. We talked about some of these signs: halo, battle, raccoon. Even if you can't remember which is which, you got to know that they all indicate bad things. I want you to think of your differentials with your TBIs. Is this a TBI? Is this guy just drunk? Could it be both? Sure. We want to position our guy appropriately. Not too high in the bed, not too low. We don't want to increase that intracranial pressure. If it's a true TBI, we have to reduce that pressure, whether it's through position, medication, or wonderful power tools. Whatever you need to do, get that pressure down. And of course, first and foremost, is use your patient. What is the level of consciousness? Remember, like I said, our patients are our greatest source of information, guys. Okay, guys, that was just a quick overview of treating TBI in the trauma bay. Thanks again for joining us, and as always, happy nursing.